This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
My name is Joe Sam Robinson. It's my pleasure to have with us tonight Dr. Eddie Young. Welcome, Eddie. Nice to...
So glad to be here.
Great, great. Well, now, Eddie, you're a man of many parts, and you play a central role in many dimensions of healthcare. But I think your present, I guess, role in medicine as a hospitalist. Is that correct?
That's correct.
What exactly is that? And I think it's increasingly an important part of the American healthcare system. Let's discuss that a little bit.
It's been an interesting evolution. Hospitalist or hospitalism came out of a motion to provide more efficient care in the hospital. And we've seen it happen. I've been doing it now for about 12 or 13 years.
Yes.
I trained as an internist and
Yes.
now evolved into this. Essentially, we define it as providing acute care
Yes.
medicine in
Yes.
the hospital setting.
Yes.
Now,
Now, in a traditional situation, at least when I started my journey through life many years ago as a young boy, as a young neurosurgeon, and I'm an old guy here now these days, but starting out,
young at heart.
What's that?
Young at heart.
Young at heart, I
That's
hope.
right.
But starting out, the custom would be every doctor looked after his patients in the hospital. So a doctor, for instance, an internist, would have the patients that he saw in his office. He would admit a patient and then look after the patient in the hospital, and some doctors still do that. So how is that situation changed? And then what happens, how does that happen? An internist puts his private patient in the hospital. What is your role? How does all that occur?
Actually, I started my practice that way. I did
Yes.
private practice medicine for 4 years, and
Yes.
it was a blended practice, and I took care of my own patients in
Yes.
the hospital.
Yes.
It evolved that I was much more interested in taking care of acutely ill patients
Yes.
in the hospital, and migrated in that direction. Macon is very blessed to have a tertiary care hospital that provides many levels of subspecialty care
Yes.
for patients from the outlying community. We have a huge referral area into Macon
Yes.
for subspecialty care, including your specialty
Yes.
as well. And those patients, doctors don't have privileges at our hospital
Yes, yes.
and are often in other communities far away.
Right.
So we provide consulting services, medical
Right,
oversight
right,
services
yes.
for patients with many
Right.
complicated medical illnesses in addition to the
Yes,
reason for being
yes,
in the
yes.
hospital.
Now, often patients come in from the emergency room without any kind of, managing local doctor. Is that the case?
Sure, they might be going up and down the interstate on their way back and forth from Florida or to Michigan, and they have something happen and end up in the hospital.
And so then the hospitalists are going to wind up as their frontline doctor in the hospital. Is that correct?
That is correct.
Yes. And so but maybe we could discuss that a little bit. Some of the issues that happen are access to the patient's past medical history and medical records. So if someone is driving down the interstate and something happens to them and they wind up in a local hospital, do you have access to their records or the medications, or what exactly?
Well, the patient's the first form of access, and often the travelers do have their own information
Yes,
with them,
yes.
or they have a loved one who has it.
Right.
Very often, it's not unusual for me to pick the telephone up
Right,
and talk to
right,
a doctor in
right,
Ohio,
right.
or somewhere in Florida, and get
Right,
the rest of the
right,
story.
right.
But the lack of information has never impeded the emergent care of a patient in the hospital.
So there's at least some thoughts out there about medical records and electronic medical records, so that everyone will have those access to that by a care provider just by pushing a button. Is that in the hopper, or comment
It's
on that?
supposedly in the hopper. The vertical integration of the healthcare system was proscribed under the HITECH Act that was initiated as part of the first stage of the Healthcare Reform Act. And the HITECH Act called for vertical integration of all healthcare information,
Yes.
with there being a central hub, often a large hospital, or the term accountable care organization.
Yes.
We have yet to see that happen. We don't know if it's actually going to come to fulfillment.
Yes.
The current law says that it's supposed to happen like by 2016 at the latest.
Yes.
So we will see what happens with that.
Now, Eddie, you're a man of many parts. I think in your earlier life, were you a football player? Am I wrong on that?
I played a little football in high school.
You were pretty vicious in those days, were you?
I played linebacker, but that was the fun place to play.
Well, now, as circumstances have taken you through life, you're now the president-elect of the Bibb County Medical Society. Is that correct?
It's one of those jobs you, I guess, get volunteered for.
Well, good. I'm glad you're a linebacker in doing that. So we discussed a little bit about some of the issues that are confronting health care. And actually, as your role, that's a pretty, I guess, important position to be in. You represent a lot of doctors and opinions. And we're really facing an enormous change in the American healthcare system. I mean, do you have some thoughts about that? I mean, what do you think about it?
We all think about it a lot.
What are some? Or let me ask you this question. I mean, we can say this. I mean, what are some problems right now that need resolution? I mean, what are some things that right now we need to do better with? Leaving aside what the efforts
in the practice of medicine?
Yes. Just in general, the American healthcare system. What are some things we need to do better?
We have a good healthcare system.
Yes.
We have a very elegant healthcare system that was incredibly well designed,
yes,
from the teaching all the way through to practice.
Yes.
However, there are some problems that are being inserted into our healthcare system for economic reasons,
yes,
which are creating a bit of a problem to deliver health care as we would, yes, know it from before.
Yes.
And we've seen changes put into the training process, which I think are actually inhibiting training.
But such as?
I mean, when you went through your training and I went through mine, it was actually not only a training process, but an apprenticeship. You were learning how to practice medicine.
Yes, yes.
Today, it's really more of a continuation of medical school. It's got limitations about work hours,
yes,
caps on how many patients you can see, which unfortunately in reality does not happen in real life.
Yes, yes. So I think a comment now, this is sort of the doctor lounge conversation, and in real life, many times the younger doctors are restrained from working excessive numbers of hours or doing this or doing that. And then when they find themselves in actual practice of medicine, they don't have those restraints anymore.
They're not prepared for it.
So then they have to work a lot harder than they did as a young doctor in training, and it can be.
Well, they come in, and we look at, when we bring new doctors into our practice, completed training, we look at it as essentially another year of mentorship.
Yes.
We have to complete their apprenticeship,
yes,
to teach
yes,
them how to practice
yes,
medicine. Because they'll often come out and say, well, what's my cap? How many patients can I stop at? And
now, why don't you say
if they're sick, we have to take care of them.
So apparently, if I can understand this, these days, a young doctor that's being trained, they can only see so many patients. There's a limit to how many patients they can
limit
have.
to their hours. There's a
Yes.
limit to their patients. They have very strict limits on their work hours per week.
Yes.
It comes under the category of the golden rule. He who has the goal makes the rule.
Yes.
And the federal government is paying for these positions, and they're putting these restrictions.
Now, I mean, just to take the other side of the argument, I think some people would say, well, if you're very exhausted and you're very tired, you might not be able to do a good job as a young doctor. I think that's at least the reason that was put in there. But saying that sounds reasonable to me, but one of the problems that happens are the patient handoffs. So if you're only working, 60...
It's creating patient handoffs.
There are lots of patient handoffs, and many times that's where the errors are occurring.
Exactly.
Is that correct? So you may see a patient for a bit of time, and then the patient is being passed back and forth a lot. So that's a problem with this system that it's been enforced.
A potential problem that is creating a new problem for itself.
Yes. Is there any? I mean, just to ask the question, is there any? Evidence that the training scores have diminished, or I don't know if one can judge that.
Well, the whole purpose was to make sure that they passed the test well.
Yes, yes.
And to lower risk in the hospital.
Yes.
Remember, hospitals are sharing the risk for these patients because they're employing the residents, so therefore the malpractice risk actually rests on the hospitals themselves.
Yes.
So these rules actually, to me, have created a shift in liability from the hospitals in the training to the practitioner afterwards.
Yes.
And so it's an interesting thought that we'll only see in a generational study as it goes forward.
Yes. So it's an issue, isn't it? I mean, I would say traditionally the idea is if you were a doc, it was this extraordinary life commitment. When one was a resident, 120 hours a week was the norm. That's the way you do it. You just have your life that way. You're devoted to your profession. There's nothing else except your profession. And there's sort of a cultural change where I guess young doctors in training can still work on their tennis game. I'm exaggerating slightly, but I'm sure young doctors will attack me for saying that. But there's a certain restraint that is there.
There's lifestyle issues that are becoming to the forefront that was not part of the traditional part of being a physician, and so you're pointing it out. It's true.
Well, now Eddie, I guess
might be a better term.
Right. I guess we've bounced the basketball of what we think could be improved about some of the training issues. Are there other things that you have a comment about in the way the healthcare system works or could be improved, or some of the issues that are coming down at us with the reformation of the American healthcare system that's in law? Do you have any thoughts about any of that? So-called Obama healthcare plan?
There's obviously lots of directions that you can go in discussing that. The question, that's facing many doctors today is that the doctors have been underneath the black angry cloud of a potential rollback in Medicare fees to doctors that is facing us.
Now, what would that mean? Many people would say, well, the doctors are flying around in their jet airplanes or whatever. It's not actually the case, but what happens when those fees are cut?
Well,
back?
here's an interesting thing. Doctors employ people.
Yes.
Doctors, you have how many employees in your own office?
It's a good question.
You have a lot,
sure.
right? You have a lot of employees in your
I wish
office.
I could tell you the number, yeah.
But if Medicare cuts your fees 30%, how many employees would you have to lay off?
It's going to be difficult to do that, isn't it? And that's
the whole point. You're going to have to lay off people, and a lot of the people who work in healthcare
yes.
are single moms.
Yes.
Who are the single providers,
right.
and are relying on their health care from you as far as their packages. And so you're actually creating a ripple effect through the system because doctors are the single earners that are providing for those large communities that are working for them.
Right. So it's a rather complicated story. So it could be that what happens, and these are confusing times we live in, but if one group of patients basically has these cutbacks, then it might be difficult for those patients to get access to health care. Is that a fair statement?
It is.
And so many times people might have a very difficult time finding a physician to look after them if the physician the numbers won't work for the physician to keep his office open.
Well, physician practice is obviously a business. They have to pay their employees and pay the rent, and they have to keep the lights on and pay themselves eventually at the end of the day.
Yes.
So most accountants will tell a practicing physician that to diversify their income through different insurance payers.
Yes.
So if they're going to tell them, don't take all Medicare patients lest the government cut back on you. So most doctors in our community are already capped in how many Medicare patients they're going to take anyway, and a lot of the patients have already found this out.
Now, is what happens, just assuming that we have this kind of dysfunctional healthcare arrangement, which, many observers would say that's the case, if the government were to do that, then that might force people to go to the emergency room. So if you had trouble getting a doctor to look after you as a private patient and you were a Medicare patient, to get treatment, you would have to go to the emergency room. Is that a fair statement? That's what would happen.
That would be emergent treatment.
What happens?
What we're saying is that what they're missing is a lot of the preventative treatment to try to keep them out of the hospital in the first place by going into a physician and seeing somebody when they're well to try to have their blood pressure or their diabetes diagnosed and properly treated.
Yes.
So obviously the emergency room is not the ideal place to get
that care. And I think most
of
our observers would say that would not be their optimal way of dealing with some, relatively trivial problem, is to go to the emergency room. It's a long wait. It's just and it's expensive. The other thing that happens is it's an extremely expensive form of healthcare delivery. So if the government were to arbitrarily diminish one particular class of patients, being the Medicare patients. So if the Medicare patients took some kind of just hit and it forced them to go to the emergency room to get their care, then it would wind up being a more expensive process. It would cost ultimately society more money.
It would raise potentially the unemployment rate. It would create more people on the unemployment rolls, create more cost in the emergency rooms. It's going to bog down the emergency rooms.
Yes.
And wait times are already long, and it's going
Right.
to deprive
Right.
people who need emergent care from being seen in a timely manner. Sure, it's a huge ripple effect through the
Now,
system.
now, Eddie, here's the situation. I mean, we're physicians. We've got this tremendous increase in healthcare costs. I mean, we can say the government is going about it in the wrong fashion and doing this and doing that. What can we do? I mean, what's our role in trying to make these numbers work? I mean, society can't keep
Here's an
them.
interesting question. I had an accountant ask me on the beach this summer. He looked at me and said, you know, Europe and the other countries managed to pay for their health care around 10 to 11 to 12% of
Yes.
their GDP.
Yes.
He said in the United States, it's somewhere between 15 to 20% of the GDP.
Yes.
He said it's way too expensive in this country.
Yes.
And I said, have you ever been and seen a European hospital?
Yes.
You know, and have you looked at wards? Have you seen getting cared
Yes,
for in
yes,
wards
right,
and those
yes,
type of things?
yes.
Part of the cost of our healthcare system is capitalization of the system.
Yes.
We have very nice hospitals. We have
Right,
very nice
right, yes,
facilities.
yes.
They're recapitalized as part of that payment. I would even venture to say that 15 to 20% of the GDP is correct.
Yes, yes.
We might not need to pay for so many wars. We
Right,
might need to
right,
re-diversify
right,
the
yes,
money
yes,
a little
yes,
bit. If healthcare
yes,
is important,
yes,
then focus
yes.
on that.
Well, I mean, okay. I mean, there must be something that we as physicians can do. I mean, just to say,
I believe
all right,
we've done a good. I believe we've done a lot.
Well-
you know, I mean, you know, can we as physicians help our patients actually lose weight? No. We can advise them. Can we as physicians
Yes,
stop
yes,
our patients
yes.
from smoking?
Yes.
No. We can't do that. But we can advise them.
Yes.
So actually, a lot of the onus of the healthcare cost belongs to the patient.
Yes.
Preventative care
Yes, yes.
is a responsibility of the individual.
Well, let's discuss that a little bit. So, what I guess the paradigm that's out there is that in the United States, a huge amount of money goes into the healthcare system, and then when the results are compared with other countries, people say, "Well, look, trillions of dollars are spent, and here are the results. They're the same as there's no difference between the U.S. and the Japanese. In fact, the Japanese are healthier." But really, some of the major variables are things like tobacco use, obesity, appropriate neonatal care, violent antisocial behavior. I mean, there are all kinds of things. Drug compliance with medication.
A lot of it gets back to educational issues.
So there's a substantial patient issue in there. Well, should the doctors do? I mean, there must. What I'm trying to say is we're co-insurers in this situation. We've got to recognize that there's a huge amount of expense, and what can we do? There must be something we could come up with. Better education. What about? And what I'm getting at is actually the hospitalists are trying to do something, aren't you? You're trying to get the patients out of the hospital sooner. Are you working on things like that, or maybe you can speak to that?
A very wise older doctor told me one time, you can only reduce the length of stay so far.
Yes.
Without hurting the patient.
Yes.
So we can do certain things in the hospital
Yes.
to reduce costs, but
Yes.
the way the government healthcare system is already set up to pay for that, the cost is fixed already. We're not
Yes.
adding cost to the care when
Yes.
we take care of the patient. The government's only paying one fee for that
Right.
hospitalization.
Now, is that a mistake? In other words, should it be, and these are the issues that are being discussed out there, is the idea, it's outcome. So you have disease, whatever the disease is, and all the people that are trying to help you overcome that disease, if they're successful, they'll get $10. If they're not, they'll get $5. I mean, do you have any thoughts about that? Some kind of different payment arrangements? Any thoughts? I mean, what are some things that ought to be thought about to at least examine the situation?
I wish I had a humorous comment to describe, I mean, to really appreciate what you're saying, but
Yes.
what you're saying is that we're taking our role as an advocate. We're supposed
Yes.
to be advocates for the patients, for the health care.
Correct, yes.
And for their system.
Yes.
And then we're being transformed into a parent. That
Yes.
we're supposed to also at the same time be joined at the hip with them
Yes.
and do things
Yes.
for them that they haven't learned to do for themselves.
Yes.
I don't know that that's
Yes.
a realistic model, and I think it's a great way to get doctors to buy into losing a lot of money.
Yes, yes.
I think it's unfortunate because every one of those systems are described as a positive way to impact
Yes, yes,
healthcare,
yes.
but what it comes down to is it's an unfunded mandate to reduce paying doctors.
Well, I mean, it's a complicated story. So things I've suggested are things that are on the table as far as changing the healthcare system because, I mean, I would speak frankly here. The the argument can be made, this is a good investment, this is not squandered money, everything is good, we're getting a good bang for the buck out of this. But I would say the popular will is just the expenses are just they're going up every year, and the system won't last. I mean, I think I could say that. And some kind of thoughts ought to be out there. And I mean, if the doctors aren't able to easily, I guess, as you say, maybe their role should be a more restricted role. If that's the case, then the government or someone else is going to put a system in place. I mean,
well, I mean, how can you, once again, you're going to get back to individual rights. How can you hold accountable a 600-pound person hold me accountable for a 600-pound person who is a medical disaster waiting to happen?
Right.
You know, some of the smartest people in the healthcare industry are actually actuaries.
Yes.
And those actuaries can look at this situation and come back and tell me what statistically is going to happen. And there's good patients that take care of themselves. There's the unfortunate patients that get diseases they can't help. There's accidents. But then there's a large proportion who are just non-compliant people who don't care for themselves.
Right. And I mean, another thing that's out there is comparing the statistics between Japan and the U.S. The amount of obesity is just an extraordinary number here. It's rocketing up. So I think maybe the numbers, the body mass index over 40% is some huge percentage of the population. So we have all these difficulties. And it may well be the physicians can't necessarily change the system, but they maybe point out some of the problems, I think would be at least one thing to do. And so one of the problems you're pointing out is that just the patients themselves are not so concerned with their health as much as they should be. Is that a fair thing to say?
Well, I mean, the federal government, if you weigh 600 pounds and you're disabled, the federal government pays you to be that way. They'll give you a chair to ride around in, and you'll get a check every month, you know. So I mean, there's an incentive actually to become disabled by being obese. You know, and then at the same time, they're going to try to hold us accountable to get them well.
Another thing I can extract from your comments here is that in some ways the government has not solicited physician support or put them as part of the process and whatever kind of changes are out there. At least I have the sense that would you agree with that? In other words,
in a realistic way, that is correct.
Whatever changes that are being done, they're just being done. There's a new.
It's an academic thought. It's
a new dictate. A new dictate is coming in, and this is what you have to do this and do this. And if the physicians are the people that are actually, I guess, making those decisions, and they're not on board, there are going to be some problems.
Is the federal government's real concern at improving the individual, or is the federal government's real concern at saving money?
Well, that's a rather good question. What do you think? What do you think?
By their actions, it's to save money.
Yes.
Because they're writing the check, and that's all they talk about. You know?
Yes.
Now, so therefore, every one of these rules that they've imposed, underneath it has the goal of saving money.
So, do you think that that patient welfare is going to be penalized? In other words, when we hear these different reform, I guess, ideas that are out there, do you think the end result is going to be some kind of healthcare rationing and some kind of penalty to patient welfare?
In the current mode, absolutely.
So you think this is coming down the pike?
Unless we can break the true choke on the healthcare system, which is the third-party payer system.
Yes. Now, have you heard in the doctor's lounge many physicians getting very nervous that they and their families may be in this new healthcare system? Their personal health could be at jeopardy with they might not
as far as how they do their own personal health care?
Yes, how they're going to be treated in a new government regime in 2020, or any thoughts
I haven't heard that discussed that way.
You must be a younger doctor.
What I'm hearing doctors concerned about is their ability to even practice medicine.
Yes.
And looking at and saying that if the constraints financially on me are such that I can't meet my obligations, they're going to have to do something else.
Yes.
And which would be very unfortunate to have experienced doctors fleeing medicine if it becomes too confining to them.
Yes. And so what are some things that irritate doctors these days? I mean, is it paperwork? Is it just the fear of this new government regulations? The diminution of revenue?
Yes. You're doing a good job.
Is that some of the issue? Well, no. I mean, can you? So you think the physicians are getting nervous about the whole arrangement that's out there?
We're getting drawn deeper and deeper into a web from which we cannot escape. You mentioned earlier electronic health records.
Yes.
right now, electronic health records are these wonderful documents that meet governmental standards.
Yes.
But if you've ever sat down and tried to read an electronic
Yes.
history and physical, you can't get anything out of it because all they're doing is meeting the definitions of what the government want them to put
Yes,
into it.
yes.
It meant a lot more to me when I could read the handwriting and know what they were saying.
Right. Now, do you think your opinions are making it to Washington? In other words, one of the things that seems to be happening is a lot of the changes that are being discussed and are on the way are sort of top-down changes. So the center is passing these UKASI, which is like the old government Russian word for, I guess, a central dictator or central law. These UKASI are being propagated, and there hasn't been input from anyone in the periphery. Is that a fair statement?
Well, actually, I'm very pleased at what's going on in the state of Georgia and our representation at the national scene right now. We've actually got an orthopedic surgeon as one of our congressmen.
Yes.
Who is Tom Price, who's very active
Yes.
in helping trying to institute some sanity in healthcare reform and
Yes,
legislation. There's many others, and we've got a very strong delegation in Washington. So yes, I think, and actually they're supported in a great deal by
Yes.
our own organization, the Medical Association of Georgia, and we're
Yes.
able to communicate our concerns up through that.
Yes.
You mentioned I was incoming president of the Bibb County Medical
Yes,
Society.
yes.
We can take the concerns of this community through the Medical Association of Georgia
Yes, yes.
and go to Washington with it and
Yes.
try to impact that. Or we've got a great delegation that works with the American Medical Association who has a large impact on healthcare.
Now, let me discuss the American Medical Association. My understanding is they supported the reform that's the so-called Obamacare. They were supporting that. Do you have any comments about that? I mean, this is our
They were profoundly chastised by a large part of the medical community, including the Medical Association of Georgia.
Yes.
Chastised them as an organization and
Yes.
told them that they
Yes.
wanted them to withdraw their support. So by their own stance, they weren't representing everybody.
Yes.
It's the same as our government.
Yes.
They say things, but they don't represent everybody.
Now, did the American Medical Association ever repent?
No.
Or so they still support.
Not that I'm
the-
aware of.
So, I mean, that's one of the issues that's out there, and I think a minority of physicians are in this organization.
Well, but there's a financial tie that not a lot of people talk about. But
Now, this is your chance to talk about it in public.
But the ICD-9 system that is used by the federal government for it's a documentation system for the healthcare system is actually proprietary to the American Medical Association, and so it's a licensing process back and forth between the federal government and the AMA. So there was some concerns about the pressures to comply.
Now, that's a rather serious allegation. I mean, really it is. I mean, do you think that the American Medical Association sort of was
Leadership.
bought, well, that's
Leadership.
right,
I'm
were pressured into supporting this because of financial ties with the government?
It's been blatantly said by other people than me.
But did the leaders of the American Medical Association get any money for this? Or
I would have no idea on how to say that. I mean, but all of these, to have a source of income for any association is a very important thing.
Yes.
And the source of income on this product is very big for the AMA.
Yes.
So,
That's an interesting line of inquiry. We'll have to talk some more about that. But in any event,
and I'm certainly no expert on it. I am not a member of the
yes,
AMA.
Yes. Oh, you're not.
No,
Now, how can you be president of the Bibb County Medical Association, a member of the Medical Association of Georgia, and not be a member of the AMA?
Easy. We untied that relationship many years ago when the AMA made another foolish move when it
Right.
associated itself with a large corporation for financial reasons.
Right. So one of the things that's out there, maybe the public should understand this, there's some complexities in the different kinds of doctor organizations. So there's a lot of disparate opinions and ideas, and I think with what you've expressed is not an uncommon response to the AMA.
When the president announced his health care reform, there was a lot of doctors behind him in white coats.
Yes.
They didn't represent all of us.
Yes, yes.
Just as the AMA does not represent all doctors. There's different surgical societies.
Yes, yes.
So it's a very complex system.
Just like our country. So we have a lot of ground to cover as we go through this, and I don't think we can say what's going to happen one way or the other about the change in the American healthcare system, but it's...
Other than change will happen.
All right. Now, Eddie, I'm going to give you the last 15 seconds to make any kind of comments you want.
Well, the comment is I'm proud that you're doing this, and I've certainly enjoyed the opportunity to be here. And I can assure you that Dr. Robinson will continue to bring y'all interesting viewpoints, and I would love to be part of that.
Well, great. Well, thanks so much for being here, Eddie. It's been a real privilege to talk to you. We'll have to have you back, and keep up your good work.
It's an extenuation of our Dr. Lounge talk.
That's right, it is. So thank you for coming.
Thank you.
Yeah, that's good.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.